morning, everybody. It is lovely to be here. Welcome to the Physician Enterprise Clinical Grand Rounds. It is my absolute pleasure to introduce our speakers this morning. We have Jennifer Posey, MD, PhD. She is an assistant professor in molecular and human genetics at Baylor College of Medicine. Dr. Posey has a clinical interest in medical genetics and sees patients in the adult genetics clinic at Baylor. In addition to her role as a clinician, she runs a very active research program. You may be seeing her name in multiple ways. Her research interests lie in relationship between genomic variation and clinical phenotypic expression, and how this can be leveraged to develop individualized treatment approaches. She has a very lengthy bio, and I would love for all of us to read all about it. One of the most impressive things to me is as a physician scientist and a medical and human geneticist, Dr. Posey's ultimate goal is to able to translate our understanding of the relationship between an individual's genotype and phenotype or disease trait into treatable information in the clinic. So really bringing it back to the chair side or bedside, depending on which setting you're in. Welcome, Dr. Posey. Our next speaker is Hitashi Bansal, MS LCGC. She is a cancer genetic counselor at Virginia Mason Franciscan Health. She graduated from California State University Stanislaus Genetic Counseling Program in 2020, and she has immense clinical experience in thinking about genetics and how it relates to oncology and prevention. Next speaker is Jill Tapper, MHA, CGA, SCP. She has over 20 years of experience leading the development and implementation of genetic and genomic-based precision medicine services and programs in the academic medical center, community health system, and commercial company settings. She was part of the team at Medical College of Wisconsin who built one of the first genomic medicine programs based on use of whole genome sequencing to guide the care of pediatric and adult patients. And she has joined Common Spirit Health as a system director of precision medicine in June 2022. So welcome to all of our speakers. I will be our moderator for this morning, and I apologize to you for talking so much today, but I think you are in for a treat because we hope it will be a very interactive session. So let's get started. Fantastic. So today's topic is clinical genetics and sequencing, the how and why of ordering and interpretation. And we mentioned our faculty. I am your moderator, and we have no disclosures across all four of us. Our learning objectives for this morning. In brief, we're talking about genetic testing, methodologic concepts, how do you distinguish between interprofessional roles in genetics, recognizing when to involve genetics for a formal consultation, thinking about testing. So what is the difference between direct to consumer testing versus consumer initiated testing, and why does this matter? And understanding the implications of what some of us may be reading in our reports that says variants of uncertain significance. And what does it mean, and how does this affect our patients, and what should we be counseling them about? So we get started. And we have based our conversation on a case, and this is a case that many of us have seen in our practice, so this may seem familiar. So patient's coming in, and her chief complaint is, I was tested. So you walk into the exam room, and Miss Rosalind Stevensberg is a 30-year-old female. She's coming to see you as a primary care clinician. She's worried about her recent 23andMe testing results showing a BRCA2 variant. There's a little Easter egg for all of you. The name of our patient, if you could figure out why she renamed her Rosalind Stevensberg, that's a treat at the end. So she's coming in, she's worried about her 23andMe testing. It shows BRCA2 variant. We're going to go to audience poll. John, could you please pull up the poll for us? Why have you, or maybe a loved one, a friend, a peer, used genetic tests like 23andMe? All right, so here's our responses. So many of us have never used a genetic test like 23andMe. Some may have used it because family history, maybe concerned about personal history, tracking ancestry, maybe finding family and relatives, and of course, curiosity. Uh, Believe it or not, it is a gift that is being touted as a holiday gift for a lot of people. And maybe after this call, you will think about giving that as a gift and what should be going as a disclaimer with it. Okay, we'll get started. So, Dr. Posey, can you walk us through what are the first few key things we should ask our patients who come in saying, I've been tested through something like 23andMe?
Absolutely. So I think that the first question that I typically have, and I think it sets the stage for a lot of the ensuing conversation that I end up having with them, is really what prompted you to do this testing. I'm wanting to know whether there is a medical concern that they have, whether it's a concern for themselves, if it's a concern related to a family history or some of their past medical history, or if it was something simply for fun. That kind of tells me that if they're coming in like our patient here, that she probably wasn't anticipating this finding, and maybe just wanted some ancestry information or to find a long lost relative. And so I think it's very, very helpful to understand what got them to this point. And so for me, that's often question number one. Question number two, I really next want to know, where are they with this information? So asking them something about what's their impression about the testing that they've had and the results report that they were provided. How do they feel about this? What do they understand of this? Have they already spoken to a member of the medical care team about this, or have they spoken to friends? Are they coming in with some sort of expectations or misconceptions that I need to address very quickly in the conversation? I think those are often the two questions that will help me understand how they got here and kind of where they are now in the room with how they're processing this information. And certainly with a BRCA2 variant, that can be something that could be incredibly devastating for someone. And so you may be really addressing up front how they feel and how they're doing in the moment before you really start to have any sort of more medical decision-making conversations with them.
Right, thank you. So I guess that goes into our next piece of our case where, we asked her, well, what are you worried about? Why did you feel like you needed this test done? And she says, well, I'm worried about my family history. I have some relatives with breast cancer, ovarian cancer, and pancreatic cancer. I was not close to my mom or her family growing up, but I just found out that she was diagnosed with breast cancer when she was 40. And as a reminder, our patient now is 30 years old, so we can understand that she might be getting concerned about her risk factors moving forward. So now that we have a context of why she's getting this testing done, um, let's talk about obtaining family history. So I want to ask Hitashi to come forward and help us guide our conversation, because we all understand in a busy practice day, we can't do our lengthy, detailed family history like we want to. So what are the key things that we should be thinking about? Hitashi?
Yeah, thanks, Ankita. Hi, everyone. So yeah, family history is so important. And as a genetic counselor, we really have a lot of luxury to get a lot of information about a person's family history and talk through it in detail to decide on, where is the patient coming from? What are their concerns? And what's really the best test for them, if at all? So, we know in primary care, you're probably not going to have that much time. So we need to just find a quick way to get really what are the most important pieces of information about this person's family history. So from my perspective as a genetic counselor, what I really want to know, if I'm getting a referral from a primary care provider, is who in the family has had cancer, if anybody. And for your purposes, for this particular patient, that is going to help you figure out, how likely is it that this patient actually has a BRCA2 variant, because usually we will see some key things in the family history if a person does. So what I would do from the start is just say, hey, anyone in your family that has had cancer. And we're really most concerned with the close blood relatives. So first and second degree, usually parents, aunts, uncles, grandparents, children, if the patient is older. Even nieces and nephews are okay. Sometimes I will get into cousins and like great aunts and uncles and things like that as well, if the patient brings something up. The most important things, if a patient says, yes, they do have a family history, is, okay, who in your family had cancer? What side of the family are they on? And if the patient knows what type of cancer was it, and roughly how old were they? So we don't need to know they were 67, 68, but were they older, like over 60, or were they young is probably the most important thing. We do know that people who are Ashkenazi Jewish are more likely to carry BRCA variants. And so, that would be a good piece of information to get as well. That might help you with your assessment. And then, of course, this patient is only 30 and she's reporting a family history of cancer. Has anyone actually had any genetic testing? Because that will also help you figure out, what the next steps are.
Thanks, Hitachi. And I think when we were talking about this session, one of the things we talked about was, like that first degree, second degree, concentric circles in the family histories. And I remember in training, one of the things I was taught was, well, when you're posing the question to the patient, kind of walk them through each member of their family. So do you yourself, does your mother, father, brother, sister, or any of your children have it, any cancer, and then move on to your second degree and third degree relatives. One of the things I wanted to make sure we were aware was, when we're thinking of cousins, of the child of an aunt and uncle, that first cousin was really a third degree, like you mentioned, rather than the second degree relative that we think about. It's great. So tell us about a little bit of these red flags that we may find in the family history.
Yeah. So there are a couple things that we will often, but not always, tend to see in someone's family if there is a hereditary risk factor for cancer running in it. I will say this is specific to hereditary breast and ovarian cancer, so something like BRCA1 and BRCA2. So really the main things are, if we know there is a risk factor running in the family, we will tend to see people getting cancer young, just because they have a predisposition. So for example, breast cancer, very common over 60, less common, in the 30s or 40s. So usually the trigger point is under 50 or so in our guidelines. Rare cancers are also more likely to be genetic. So I think a lot of you probably know anyone with ovarian cancer, anyone with pancreatic cancer, those are more likely to be hereditary than, other types of cancer, more likely to be related to something like a BRCA variant. Same thing with like a male who's had breast cancer. And then if a lot of those people tend to be on the same side of the family as well and related all to each other rather than, one on one side and one on the other side, that can also be suggestive, right? Because maybe all those people have the same risk factor. And then finally, even having like multiple primary cancers. So we'll often see in clinic, somebody that has a BRCA variant will have a family history of someone that had multiple breast cancers in the same lifetime, or even breast and ovarian cancer. So if you see any of these things, that should be a clue that, yeah, maybe there is a risk factor running in the family, and either follow-up testing should be ordered by the provider, or certainly this would probably be a good point to refer to genetic counseling if you see any of these things.
Great, thank you. So we're thinking young, we're thinking rare cancers, multiple relative in the same side of the family, or multiple cancers in a single relative. Great. Okay. So we're moving on with our case, and so Rosalind Stevensberg is now asking, I want to know. I've read a lot online about 23andMe, and there's all these questions about whether 23andMe is reliable, whether it's verifiable, whether it's accurate. Tell me a little bit about what this result verification and reliability is. So I'm going to turn to Dr. Tapper. So what is the difference that have between the many genetic tests that are available now and what we should consider clinical testing?
Sure. So there are really three main categories of testing. Direct to consumer, consumer initiated, which is also sometimes called provider mediated testing, and then clinical diagnostic testing. So this table highlights some of the key attributes and some things that physicians and care providers should be aware of across the entire test continuum. So in things like ordering and consenting, there are some big differences that are very important. Direct-to-consumer testing has no healthcare professional involvement. And that goes from ordering the test, which is done directly by the consumer, as the name implies, as well as in obtaining consent, which is done through presenting information to the consumer in writing for acceptance. So similar to how you think of kind of accepting terms and conditions. So you present a lot of descriptive information, a lot of disclaimers, followed by a, do you understand and accept? Click here. Consumer initiated testing increases the level of healthcare professional involvement. These tests must be ordered by a licensed healthcare professional. Does this mean it has to be the consumer's personal physician or care provider? No, and oftentimes it's not. So what happens in that situation is the consumer answers some test-related questions, and a physician, genetic counselor, APP, employed by the testing company reviews that information and then orders the test. So in that situation, the consenting can be done similar to direct-to-consumer testing in writing directly with the consumer, or you could have a telehealth conversation with that ordering professional. But even that conversation still lends itself towards a discussion of the test itself, not what does this test mean specifically for the consumer and the consumer's health. So that last category of clinical diagnostic testing, a patient's physician or healthcare provider or genetic counselor orders the most appropriate test based on the patient phenotype or suspected condition, as well as information like the family history, the medical history, evidence-based guidelines, all those things we just touched on as being important. And once that appropriate test is identified, that same information guides the process of attaining consent through a conversation with the physician, the care provider, and the patient. So when it comes to performing the test itself, there are also some major considerations. Very importantly, the regulatory status of the laboratory. So CAP and CLIA are the regulatory standards that govern laboratory testing. CLIA is the Clinical Laboratory Improvement Amendments. It's a federal program administered by CMS with state level oversight. And at a minimum, all laboratories that perform testing for disease prevention, disease diagnosis, or treatment are subject to CLIA standards and are required to maintain CLIA certification to operate. So CLIA adds quality control requirements, procedural requirements, as well as set some qualification standards for the personnel performing the laboratory testing. CAP stands for the College of American Pathologists, and CAP accreditation standards exceed those of CLIA by adding requirements for ensuring clinical validity of testing. It adds ongoing requirements for competency assessment of laboratory personnel, as well as proficiency testing for the laboratory as a whole. And CAP really is recognized worldwide, actually, as the leading organization for setting those standards of excellence for laboratory practice. And that so much so that CAP actually has what's called deeming authority by CMS, which means if a laboratory meets CAP accreditation standards, it's deemed to have met CLIA certification standards. So CAP also has that same deemed status with agencies like Joint Commission, OSHA, National Marrow Donor Program, so some significant health agencies. It really is the gold standard for ensuring test accuracy, quality, validity, patient safety, and any test falling into the last category, excuse me, of clinical diagnostic testing is always performed in a CAP CLIA laboratory. Now, direct-to-consumer testing laboratories are not required to maintain CAP accreditation or CLIA certification. So some do have it, but those tests do say over and over again, they are not intended for diagnosis, prevention, or treatment of any disease. So there's nothing ultimately holding them to, CAP, CLIA, or other regulatory laboratory standards. Laboratories performing consumer-initiated testing may or may not have CAP, CLIA status. Many times, consumer-initiated tests are performed by laboratories that also offer clinical diagnostic testing. So there's some added assurance there that the testing process is conducted according to clinical standards. Okay, so that's a lot of background information, but now getting to that question of the reliability of the results. So setting aside things like ancestry, non-disease traits like eye color, hair color, the aspects of many direct-to-consumer and some consumer-initiated tests that are not health and disease related. So, looking at things like, in our case, results related to disease risk, disease predisposition, and the interpretation of the information. So what do these results really tell us? This is where we really need to be aware of the differences in the types of testing. So direct-to-consumer tests and some consumer-initiated tests look at a predetermined set of variants related to the diseases and conditions they test for. So in our case example, that direct-to-consumer test our patient had looks for 3 variants in BRCA1 and 2. Now, if we look at expert-reviewed clinical variant databases that are used in interpreting clinical diagnostic tests, there are more than 2,000 known disease-associated variants in each of the BRCA genes. So when we ask, is it reliable? Does it reliably detect what the test said it's going to? For direct-to-consumer testing, we kind of have to take the company's word for it. But even more importantly, when we're asking about reliability in terms of things like giving a complete picture of a person's risk for developing a disease, or were the variants tested those that the patient should be concerned about, that's where we can't reliably say yes with direct-to-consumer testing and even some of that consumer-initiated testing. So along those lines, does every patient need to be worried about all 2,000 BRCA variants? Probably not. And a physician, a genetic counselor, another member of the care team who knows the patient's phenotype, knows the medical history, the family history, will know the right question to ask and order the most appropriate test to get that question answered. And with a clinical diagnostic test, you'll get that answer based on the same information, the phenotype, that family history, medical history, the clinical evidence, and variant reporting standards and guidelines, and to get to a reliable answer.
All right, wow, that's a lot of information, a lot of good information. So thank you for walking us through it. So it sounds like, for the direct to consumer, there's some questionable CAP CLIA approval or standards that may or may not be met. Now, one of the questions that often gets asked is, does it say it on the test? Is there some way we can figure out, like, if you're doing any of these direct to consumer, do they state CAP or CLIA on it?
So again, for clinical diagnostic testing, putting the CAP CLIA numbers is a required element of all reports.
Gotcha.
So if you look on the report and it's there, they have it because they have to include it. If it's not there, they most likely do not. So that's a good way to see. People who have it will make sure it's prominently displayed on those results.
Okay. All right. Thank you. So I guess then we've shared all this information with our patient, and now she's asking, well, I heard something about site-specific versus comprehensive testing. So Dr. Posey, can you walk us through what is the difference between site versus comprehensive?
Absolutely. So I'll start. I've added a little picture to the right of sort of a gene and its native DNA context, and just to kind of orient someone. Typically, when we're thinking about identifying or testing for a genetic change that might influence how that gene and its protein function and might cause disease or increased risk of disease, we're often but not always talking about sort of a very specific variant and a very specific position in that gene. And so if you think about the structure of genes, they're composed of multiple exons, and those will ultimately encode what becomes the protein sequence. And then you'll also have intronic regions as well. And sometimes there will be important information within those intronic regions about how the gene is turned on and turned off. In addition, upstream of the gene and sometimes downstream, you'll have other elements that can influence how the gene is turned on or turned off. And you can see here the promoter region. So most often when we're thinking about sequencing a gene or sequencing for a specific variant, we are looking for something that's in an exon that's going to influence the resulting protein sequence. And so that's what I've shown you here is sort of a particular variant that we're interested in the exon that's colored in blue. And in those situations, we often talk about variant specific or site specific, meaning a particular location within the genome that we want to test or target. A great example of that could be, say your patient says, I have this genetic change and it's a leucine position 24 that changes to a termination codon. So it's sort of a predicted damaging variant. It's a nonsense. We would call it a loss of function variant. And with that information, you can see I know exactly where that is in the gene. We don't even need to look at the entirety of BRCA2. We just need to look at that one nucleotide really in the region kind of right around it. And so a potential scenario where you might want to perform variant-specific testing could be your patient's mother is known to have this particular variant. If your patient's mother has this variant, your patient has a 50-50 chance of having inherited this. And if this variant is what's responsible for the cancer in the family, you're able to get your patient a really straightforward sort of yes or no, you have or have not inherited this risk from your mother by testing for that particular variant. You don't need to look for the rest of the gene. One of the benefits of this type of site-specific testing is that it's often much less costly to families. I actually saw a family yesterday that had a very different type of condition plaguing the family, and one of the earliest individuals affected in the family knew that she had a risk, was unable to afford and obtain genetic testing, and ultimately actually died from the condition, unfortunately. And so being able to kind of simplify the testing and look at a specific variant if you've already identified in the family is tremendously helpful. The next most common type of testing that we think about, I've actually shown here, and this is something that happens a lot in my genetics clinic. We say we do have a gene and we don't know what variant we're looking for. And so we are going to look at the coding regions of that gene. We want to sequence each of those exons because those are the components that the sequence of those exons is ultimately what drives the sequence of the protein, which you can see below is listed as a polypeptide. And so we think the biggest bang for our buck is to look for genetic changes that are going to affect the protein itself. And so a lot of genetic testing today focuses on those exons, those coding regions, and the regions that just border it on either side that can be important for how those exons are used. This type of testing, if you move forward one slide, is really a kind of a gene-focused testing. And these days, we often don't test for a single gene. We may perform a gene panel. And so you might be interested in asking the lab to analyze all of the coding positions within a particular gene or set of genes. A great example of that could be if you see a patient who comes in and has a striking history of breast and ovarian cancer, you may say, I can't tell for sure if this is BRCA1 or BRCA2. And honestly, it could even be TP53 or PALB2 or ATM. And so you might say, instead of putting all of our eggs in one basket and taking a guess that this could be BRCA1 and testing that gene, let's get a gene panel and look at all of this at one time so that you're getting kind of the information you need up front in a single test. And if you did get a negative result back, you're not kind of questioning, is there something I wish we would have tested in addition? So genes and gene panels, in particular gene panels, are frequently used in genetics clinics as a really great starting point. And again, I kind of mentioned below, when you have sort of a family history, you can't pinpoint a single variant. There's no one in the family has had genetic testing yet. So you have no direction in which to go off of. You're relying on your family history, you're creating your genetic differential, and you're using that to decide what gene panel you want to target for this patient. And then the final sort of category that I'll talk about today, and you'll notice that all of these are largely specific to sort of kind of point mutations. And there are other types of genetic testing that we'll hopefully get into on a different panel in the future. But exome sequencing is increasingly becoming more commonly used in certain scenarios. Exome sequencing you can almost think of as a panel of all 20,000 known genes that we have, all 20,000 known protein coding genes. And so it's sort of the biggest panel, if you will. And historically, people would call this whole exome sequencing, but we often refer to it just as exome sequencing now, because we do know with the technologies that are used that there are some genes that are imperfectly covered in that testing for sort of technical reasons I won't go into. So instead of calling it whole, which is maybe a bit of a stretch, we refer to it as exome sequencing. And the scenario that might come up where a person might consider ordering exome sequencing is supposing your patient has a complex medical and family history, and you're unable to define a single syndrome like hereditary breast and ovarian cancer, or a short list of syndromes that's likely to explain everything that's going on in them. A great example of this that we've seen here at Baylor is there are occasionally patients who will actually have two distinct genetic conditions when you do this type of testing, and they may be very unrelated conditions, and the patient happens to show up in your clinic and they have sort of clinical features of both, but of course they don't walk in the door going, I have two things going on kind of written across their forehead. So you're sitting there puzzling going, I don't know how to put this all together. And exome sequencing can be very helpful in some of those very clinically challenging cases.
This is great information, so thank you for sharing that with us. I want us to go back to our patient because she has more questions. She's not sure which of these tests should she need, right? We just went through a couple of different ones. Also, like, does the rest of my family need to be tested? Do my kids need to know about this? At what point do I share this information? And if I have BRCA, do I need to go see an oncologist? And these are very familiar questions that even in my practice, I have had to face sometimes, unsure of the answers. So if you could do an audience poll, John, let's see what they would recommend for our 30-year-old patient who's coming in with a BRCA2 variant. What are the next best steps? Okay, should we take a look at our answers? Hey, referral to genetic counseling. By far, everybody's saying there's something here. We're not sure. We need a little bit of assistance in trying to figure this out. And also, let's discuss some surveillance guidelines for cancers. And this is a great dovetail into us talking about, well, what do you propose as the next best steps? What are the things that we should inform our patients about? So I'll turn this over to both Dr. Posey and Hitashi.
But I think I can start. I think one of the first things that that I always sort of a process that I go through whenever I have someone who's coming to me in my clinic with a result is exactly kind of what Jill just walked us through. What type of testing was this? Is it CAP-CLIA? What was the finding? And how certain can I be that that finding is really present in this patient? In a scenario where someone brings me a direct to consumer report and they do have a damaging variant, like our patient here in BRCA2, actually one of the very first things that I want to do is clinically confirm that. And so at this stage, one of the things I'm going to talk to the patient about is, let's make sure that, that we can detect this using clinical grade testing and make sure that you really do have this risk. At the same time, though, I think it's a great place. They're obviously in your office and they are very worried about this result. And depending on their family history, you may already have a sense that, okay, this variant is there and probably it is pathogenic or damaging. This probably is someone who we're going to need to start surveillance. And so you can kind of start talking to them about what are those different surveillance recommendations for a person of her age who has this type of variant, and what would that look like? And then, of course, the other piece that you're going to want to talk to her about are her at-risk family members. And maybe I can turn that piece over to Hitashi.
Yeah, thanks, Dr. Posey. I totally agree with everything you said. I think for me, it would definitely be, yeah, it sounds like there could really be something here. And we really want to make sure that we validate that for the patient and they understand, we understand their concern, and we're going to try and work towards a next step. And so I think as a genetic counselor, though, I agree with you, Dr. Posey, we would definitely want to validate these results first before we make any further recommendations. And that's where I, am a really great resource to patients. And I don't know how many clinics actually have access to a genetic counselor, but we're really trained in, talking about all this with patients and giving them a sense of what is the actual risk? What's the chance that you have this? What are we going to do if you do? And what are we going to do if you don't? And figuring out, the best option for that patient. And then at that point, based on what we actually find, if the patient decides to get a validated genetic test, what do we tell the family at that point? So that's what I would do.
I think a couple of things that I heard that were key was agreeing with them, reassuring them, we're here, we're going to figure out a path. And then also something I heard that was very interesting was, what are we going to do if this is confirmed, but also what are we going to do if it's not confirmed? What surveillance do you need, which is great. And then I guess this dovetails into is, well, how do we access these guidelines that may be recommended when it comes to screening or surveillance, or even thinking about chemo prevention or just prevention in general, surgical procedures, things like that. So I'll turn it over to Hitashi and Dr. Posey again.
All right. So for me personally, I use NCCN. They are kind of my main go-to resource for any follow-up for patients. That's what I use. So they're really easy to access. It's nccn.org, and you can make a free account. You do need an account in order to access all the guidelines. Once you do have your account, you just go into their guidelines as highlighted on the top, and then you can download a PDF of the most recent guidelines, and you can use that, and they lay out very, very clearly, if someone has a BRCA2 variant, what's the follow-up? ATM, what's the follow-up? And so this is a really great resource. And it's also continually updated too. So definitely make sure you keep checking back every couple of months, because they usually make changes as more information comes in.
Excellent. Dr. Posey, wondering if you wanted to add anything to how do you think about guidelines and where do you access them?
I actually wholeheartedly agree. I think NCCN is absolutely the best resource. They have great detail, great references to studies. And as Hitashi was saying, one of the things that's always so striking to me is how frequently the guidelines are updated, and occasionally things do change. And so I've actually gotten into the habit of, for a particular patient that I know is coming in to see me in the next day or two, I actually go to the guidelines sort of afresh instead of relying on what I might have pulled down a few months ago, just because they can change. And I certainly never know exactly when they're necessarily going to be updated. There are some very helpful tables within the NCCN guidelines that will also give you information about the likelihood of cancer by site. So for example, if you are talking to someone who has a pathogenic BRCA2 variant, you might be talking to her, if she's female, about her breast and ovarian cancer risk. You can also provide her information on her pancreatic cancer risk. You can talk to her about the risk of breast cancer to her male family members, which is actually really important because that often tends to be overlooked in men. And unfortunately, we've in fact had a couple of men who were kind of relatives of patients of ours who kind of developed masses and didn't initially pay any attention to it, kind of thinking, well, my breast cancer risk is not anything. And so we always counsel up front, make sure your male family members know as well. So I think NCCN is just an absolutely wonderful resource and has detailed information, but lays it out in a very nice structured way.
So we have a resource to go to. And if it's okay for for this part, I'm wondering if you could summarize, what does a genetic counseling referral look like? What are the things that you talk about, um, and things like that?
Yeah. I put this in here just so everyone has a sense of like, what actually happens at a genetic counseling appointment. So basically what'll happen is after you place your referral, we usually spend about an hour, at least I do, 60 to 90 minutes actually with each patient. And there's multiple steps involved. So first step is really just getting that very comprehensive personal and family history. And that allows us to, again, like I said, what's really the chance we're actually going to find something, what's the test that's right for the patient, if anything at all. And then really just key aspect of what we do is actually sitting down and having the time to counsel them about this. What are the pros? What are the cons? Is this something that is right for the patient that's sitting in front of me? And making sure they really have a good understanding of what can come out of the test, because that's really important. And then at least in my clinic, we will be the one to order the testing. And it usually takes about 1 month for the results to come back. And so what I do is when the results come back, I always inform the referring provider of the result. And, if anything was to be found that was significant, we'll sit down with the patient and come up with a plan and work together to decide what needs to happen next for them. Usually it involves a lot of outside referrals to different specialties. So.
One of the questions that we often get is, in this phased approach, where and if at all do you sort of discuss what this means as far as insurance is concerned, whether health insurance or a cost to the patient and all of that good stuff?
Yeah, I would definitely say that's part of the counseling part. Good thing is access has become a lot better in the last, 10 years or so. And now it's definitely, at least with the labs I use, definitely not as expensive as it used to be. Most patients aren't paying more than $250 if it's denied, and that's even very few people in the first place. So, but yeah, that sort of comes after the whole discussion about, okay, do you need testing? And if so, pros and cons, cost is definitely part of that. So.
Great, thank you for walking us through this. And we're going to share this slide out because I do want to make sure we have a little bit of time to answer some of the Q&A that's coming in from our audience members, because I know that is a good, important part of it. And if in brief, you could talk about, she has our patient, going back to her, she has another question. My neighbor was also tested, and she, on her report, said variant of uncertain significance. What does this mean? What is the recommendation if we as physicians and APPs see this on a report? What are the things we should be thinking about? And I will open this up to all three of you, and then we'll move to Q&A.
I'm happy to start. I'll keep it kind of very simple. A variant of uncertain significance is really exactly that there's not enough information at this time to know whether that particular variant is influencing the gene and protein's function or not. If it's a benign variant, even if it's in BRCA2, there's no increased risk of hereditary breast and ovarian cancer syndrome. And so the first question that someone facing this result needs to sort out is, do I think that this variant is likely to be causative in this family or not? And there are times when you might be talking to someone who has an absolutely tremendous positive family history of cancers that are consistent with the types of cancers you would expect for a BRCA2 variant. And there may be other times where you're talking to someone that has an entirely negative family history. And so I think that that's a very important first step. If there are multiple affected family members, you can see if they also have that variant. And if they do, there's a much higher likelihood that variant is actually damaging.
Yeah, and I agree with Dr. Posey totally. Good thing to know is most variants of uncertain significance do turn out to just be benign variation, nothing for the patient to be worried about. And so we usually, sometimes there are exceptions, but we usually do not recommend putting someone on a BRCA2, management plan if it's uncertain, because what if it is nothing? We don't want someone to go off and get a surgery that they don't need if it turns out that this is just a benign variant. So in my practice, In most cases, if we see something like this, we counsel the patient like, we don't really know what it is yet. So we will use your family history to decide what your management plan is going to be. And we will let you know once we learn more about what this variant is, if there's any updates, and we'll plan from there.
Okay, great.
Yeah, I'll just
So,
add quickly,
yeah.
on the end of the VUS being on a lab report. So while it's confusing and does add, extra angst to an already anxiety-filled situation in a lot of cases, it's important to have it because of what Dr. Posey and Hitashi just mentioned about it could be nothing. It could be that it's something if it's in your family, but you really want to know that it's there, because what if you do have a novel variant in your family? Right. And we just haven't, as a scientific and genetics community, built that evidence yet to say this is a known pathogenic, known to cause disease variant. So it's really important, even though they are confusing, to have those VUSs and know about them and know what they are.
And you can follow up with the laboratory, years down the road to ask, is there new information? I think that's the other kind of important piece. They hopefully won't be uncertain forever.
So it's not a one and done. It is a one and follow up. Continued surveillance. Gotcha. Okay. Thank you, all three of you. And we know that we promised an Easter egg in the slides. So the reason our patient was named Rosalind Stevensberg was because of these three wonderful women in STEM: Rosalind Franklin, Nettie Stevens, and Esther Letterberg, who each had a key role to play in how we think about genetics today. So with that, I think we'll go to the audience Q&A, John. Okay. So I know that a few people are very excited to ask you some questions. So first question is, what about half siblings? At what point do you consider them in the family history? And is this important? So I'll give that to Hitashi. Tell us where do you consider family history and of half siblings specifically?
Yeah, half siblings, very important. I guess they're technically second degree, but yeah, I would absolutely grab half sibling information. Good question.
Thanks. The next question, similar to what we asked, which was, how do you counsel patients about life insurance, how this will affect it? And I know in our own discussion, we had talked about privacy and what this means when you get genetic testing done. So I was wondering what you all think about things to be concerned about or things not to be concerned about when you get testing done when it comes to insurance, life and health insurance, and privacy.
So I can start on that, although I'm sure Hitashi will have some thoughts as well. There's a Genetic Information Non-Discrimination Act, and it does protect us in the US against discrimination by employers. There are sort of a few kind of caveats to that, but for employers, if I think it's more than 15 employees, unless you are a federal employee, or I think some situations for VA patients as well. And so in terms of employment, you should not be discriminated against based on your genetic testing results. The same is also true for US health insurers. They have to follow this act. And so you should not be discriminated against by health insurance for genetic testing results, even if the testing result is predictive. So say you don't have cancer now, but you're found to have an 80% lifetime risk of colon cancer. Life insurance is not covered under that policy. And that's something that's part of our pre-genetic testing, our pre-testing counseling discussion with patients. We actually have had a few patients say, let's hold off on the testing now. Let me go get my life insurance and I'll come back to you in about 6 months once I have that all set up. And then I want to proceed with testing. So particularly for predictive testing, where someone's coming in and they're unaffected and in generally good health, but they want to know about a risk that could substantially influence how life insurance is going to view them. That's very important. One thing I'll mention also that came up in a recent consenting visit that I had, for individuals who live and work and are insured in other countries, each country has their own policies, and many of them do not have a policy that addresses this. So this is really true for individuals who have health insurance in the US and are employed in the US.
These are key aspects of answers that we need when we're talking to our patients. So thank you for walking us through it. Hitashi or Tapper, anything else you would like to add to that?
I totally agree. Yeah. And this is a really, really important part of my conversation with patients. And this is part of the reason why we really encourage someone to go see a genetic counselor, because people need to know that, I mean, that is an important piece of the informed consent process. And we get so many questions about it. So, a lot of what I do with patients is really helping them weigh. It's like, okay, well, we talked about, there's all these good things that can come out of it, but, you do need to know that this is a possibility and it can and does happen to people. And how does that weigh into your decision making? So.
Yeah, and just one other aspect of privacy is a lot of times patients are worried that if it is something that is hereditary and other family members could be affected, that doesn't mean that, your physician or genetic counselor can go out and start disclosing your test results and your information to your family members just because you're related. That same privacy of your medical information exists, whether other family members are involved or not. It's really the patient and the family, how much they disclose to one another. Of course, Dr. Posey, Hitachi, other genetic counselors and physicians can help facilitate the, getting that information to the family, but, your medical information is still private, just as any other would be, even if it's a, familial genetic result.
It's absolutely treated like other medical records. I mention this because we've had a few patients who said, can you just not put this in my chart, or can you not share it with my other providers? And if it's a clinical report, the way that we handle this in my office is no. If you don't want the test to go into your medical chart with us, which is shared with, because of Epic Care Everywhere, is shared with many other areas and offices, then we're not going to control that way. So the testing simply shouldn't be done if you have that level of concern.
And I think that dovetails nicely into one of our last audience questions, which is, how do you handle these reports when it comes to documentation? Is this something that goes into discrete fields in the EHR, the EMR? What if the patient is doing this as an electronic intake prior to their visit, or are these documents like scanned and then archived that you have to dig up at some point in the future? How does the documentation look for you guys? Because I know it'll be very different depending on where you are.
I mean, I can start also.
Yeah.
We've certainly had patients come in with a thumb drive of their raw 23andMe results, and I hand it right back to them. There's no good place to store that in Epic, number one, and number two, because those data were generated in a lab that's not CAP/CLIA certified, no medical decision making should happen because of those results. And I think it creates a lot of confusion if we as a genetics clinic kind of upload something that says something about a possible BRCA2 variant, knowing it's not been orthogonally confirmed and handled the way it should, at least not yet. And the last thing you want is for somebody else in a different care team to see that and to start making medical decisions based on something that hasn't even been confirmed yet. So for us, it's very much as this kind of CAP/CLIA confirmed. We'll write about it in our note, patient, kind of reported this, but we're not going to treat those the same way that we would a true clinical results report. Now, if the patient uploads it directly, then it's kind of already in there, and we're going to be very clear in our note about how we interpret the data that are there.
This is fantastic. Thank you so much for all three of your expertise and time. And we are looking forward to further discussions about perhaps other topics related to genetic testing and how we can make it a reality and help our patients. So thank you very much.